Just 8 o'clock. We'll give a couple of people a few minutes to straggle in, both online and in person, and then get started. Talk's not going to take the full 60, is it?
No, it should be. Interesting people find it, but have to leave halfway through.
Yeah, probably through. So, don't see camera. I don't think. He's missing here. He's This is the lab meeting yesterday, so he should be around today. Oh, should be an accident, right? I mean, I basically told him to sort of come and use a few days to sort of a little bit, get a sense of the why to start with.
It's turning out to be promising.
Yeah, there may be something, so there may be a year's opportunity as well, which we can sort of talk about. Should we get started? Okay, why don't we get started? It's quite an echo there. So welcome to Cardiac Sciences Grand Rounds. As we wrap up the year, we are trying to get back to what was normal to some extent. So this is our second hybrid session. I suspect that we'll be trying to do a little more in-person work in the fall as we start up for real for the 22-23 year. So welcome to those of you that are here in person and as always, those on Zoom. So today we have a visiting speaker from Toronto. Dr. Heather Edgell is Associate Professor of Kinesiology at York University. She's an integrative autonomic and cardiovascular physiologist who's trained both extensively in Ontario as well as here in Alberta. So welcome home, Heather, so to speak. And she's actually on sabbatical and doing some work in collaboration with us and taking it back and forth to work in Toronto. So we're excited that Heather's been able to spend some time with us and visit. And part of the price of that was we roped her into educating us a little bit on her work and her interests. As you know, the autonomic physiology is complex and there's a lot of variability. And one of the issues is around women and the effects of both their menstrual cycle as well as drugs that can alter the menstrual cycle. This is critical in our work in POTS, for example, but more broadly, I think dovetails nicely with the Libin Women's Cardiovascular Initiative. So in that spirit, Heather has picked a topic that really hits at the heart of several interests across the Libin platform. So I'm excited to hear Heather educate us on this topic. And with that, Heather.
Thanks. Thanks for that great introduction. I see some people still trickling in. Welcome. So as mentioned, I'm going to talk to you about my work in the menstrual cycle and oral contraceptive use. A lot of my work is on this. I'm in a kinesiology department, so I have ready access to young, healthy participants. I do some work in clinical, but I'm not going to be talking about that today. There we go. So in regards to disclosures, I don't have any disclosures to any of the data that I'm going to be showing you today. I do have one agreement with a company called Q30 Innovations, but I'm not going to be showing any of that data in the work that I'm showing today. So in regards to an outline, what I'm going to teach you about today is just in general, estrogen and progesterone, the natural cycling estrogen progesterone, as well as the pharmaceutical or exogenous estrogen progesterone that you find in oral contraceptives. I'll briefly talk to you about their influence on exercise capacity. And this is not my work per se, but I want to introduce the fact that both menstrual cycle and oral contraceptives can influence exercise capacity. And then I'll also talk to you about their influence on orthostatic tolerance, which I know a lot of people have interests in, as well as I do. I will be talking about both cardiovascular considerations, respiratory considerations, and autonomic considerations in regards to orthostatic tolerance. So for those of you who are not familiar with a normal menstrual cycle, this is a graph. I'll use the mouse here so that I can show you. In the middle panel here, this is both estrogen and progesterone. So we've got estrogen in the orange and progesterone in this more yellowish color. In what I call the low hormone phase, this is the early follicular phase. So the low hormone is generally considered from 0 to 5 days, with 0 being the first day of your menstrual cycle. And this is what I call as the low hormone phase, because oral contraceptive users would have a placebo pill during this week, or at least certain types of oral contraceptives. But the types that I'm working with are more the cyclic kind that have that 1 week of placebos. And then later on in the luteal phase, this is what I call the high hormone phase, which is typically in and around days 18 to 24. So this is post-ovulation, and this is where you have high levels of both estrogen and progesterone. And in regards to oral contraceptive users, this is going to be during the 3rd week of their pill. And sometimes it's the same dose for all 3 weeks, but sometimes this 3rd week is the highest dose. And so that's why we call this the high hormone phase. Some of you may or may not know that sex hormones have both genomic and non-genomic effects on the body. So this is including testosterone as well as estrogen and progesterone. So the non-genomic pathway you might be more familiar with, but that's where the sex hormone, one of the 3, can bind to a membrane-bound sex hormone receptor, and then that elicits a response. In regards to estrogen, a common one is via endothelial nitric oxide synthase, which is why estrogen is deemed to be a very powerful vasodilator. It can also work through a genomic pathway where it binds to a receptor that enters the nucleus and then can affect protein creation. So you can actually, with estrogen, create more endothelial nitric oxide synthase, as well as many, many other hormones. So this is why these sex hormones can have such vast array of effects, because you can have both these fast-acting pathways as well as these long-acting pathways via the creation or blocking of protein synthesis. That's the cell biology as we get, but I just wanted to introduce the concept to everybody. So first off, I wanted to introduce you to the exercise capacity. I'm going to start off with the menstrual cycle, and it's not very well known how well or if the menstrual cycle does influence exercise capacity. However, it's not really been studied widely yet. So I'm hoping that changes in the near future. In particular, this is important because those exercise studies that do exist don't necessarily investigate the flow phase or the low hormone phase. And that's important because that's when there's active menstruation. And therefore you could be exhibiting a small amount of anemia, a decrease in plasma volume, and those 2 things by themselves can influence your exercise capacity, because those are going to be influencing your oxygen carrying capacity and delivery. Similarly, the high hormone phase that I mentioned, or the luteal phase, in those who are not taking oral contraceptives, that phase is linked with higher sympathetic activity at all time points, which can certainly affect your exercise capacity because it can influence your peripheral resistance and your blood pressure, as well as it can influence your metabolism, which is clearly a part of your exercise capacity. In regards to oral contraceptive use, this is again not well studied at all. And there are a couple of studies out there, which I'll introduce you to a couple of them. And I feel that it needs to be studied more because oral contraceptive use is linked with greater ventilation at all time points. And that greater ventilation, it could be a good or a bad thing for your exercise capacity. It's good because clearly you want to ventilate while you're exercising, but bad because you might reach your maximal ventilatory capacity earlier. So you might be limited to your exercise capacity just because you're in that high hormone phase. A study that came out just last year did investigate the menstrual phase as well as oral contraceptive use in a CPET or cardiopulmonary exercise test. So what they did in the first 2 columns, these are naturally cycling women in the early follicular and mid luteal phases. And then we've got oral contraceptive users during the placebo pill or the active dose. And in this CPET, you can see here that both the VO2 max and the VO2 max normalized body weight. There wasn't any influence of menstrual cycle or oral contraceptive use here. However, what I want to highlight to people is that one of the endpoints of a CPET is the respiratory exchange ratio, especially in newer modern machines like a VMAX system. A lot of the times people use this RER point of 1.1 or 1.15 as an endpoint, and they might not push their participants further than that 1.1 line. And you can see here through the menstrual cycle, so the follicular or low hormone phase are these black dots, and the luteal or high hormone phase are these white dots. The high hormone phase have a lower RER, which means that they have greater fatty acid metabolism, potentially from that greater sympathetic activity. But if you draw this line across here from the 1.1, you can see that in the follicular phase, you're only at about 75% of your maximal exercise intensity, whereas your luteal phase, you're up at about 90, 95. So that's a 20% difference if you're using that 1.1 as a cutoff point. So anybody that you're testing in the early follicular phase, you could be underestimating their VO2 or their max exercise capacity by about 20%. This is a less common test, but it's a Wingate test measuring the anaerobic activity. And what we've got here is the blood lactate concentration on the y-axis. We've got naturally cycling women in the low hormone and high hormone phases, as well as oral contraceptive users. Now, there was no effective menstrual phase here, but the oral contraceptive users on the whole had a greater lactate production during this Wingate test. What that could imply is they might actually have more type 2 fibers or bigger type 2 fibers, creating more metabolites when they exercise, which again could clearly influence their exercise capacity. So while a lot of this work hasn't been brought together into one big study, there is a lot of potential here for the menstrual phase and oral contraceptive use to influence exercise capacity if it's done well and controlled for properly. So just to sum up there, the CPET measures, the cardiopulmonary exercise test measures, are not influenced by oral contraceptive or menstrual cycle. However, it all depends on if they use that 1.1 cutoff point or not. The high hormone phase has greater sympathetic activity and also therefore more fatty acid metabolism. And the OC users generate greater lactate during a Wingate or anaerobic exercise capacity test. So moving on, does anybody have any questions so far? Or we'll move on to the orthostatic tolerance part. We're good. Save your questions up for later then. Oops, sorry. So moving on to orthostatic tolerance and how the menstrual cycle and oral contraceptive use can influence tolerance. Dr. Raj did a couple of studies in the past looking at lightheadedness through the menstrual cycle in both healthy controls as well as in postural orthostatic tachycardia syndrome and vasovagal syncope. And these are just side by side here so that you can see that in the menstrual phase, which is the low hormone phase, there is greater lightheadedness in the control and the POTS patients. And again, here in the menstrual phase, there's greater lightheadedness in the vasovagal syncope and the control patients. You can also see at the late luteal, there's this increase in all three groups. And that would be because this is when the hormones are starting to drop off. So in these two phases where the hormones are dropping off or non-existent, very low, that's when the lightheadedness is greater. I believe these two studies included women that included oral contraceptive users as well as non-users. So that might be something to do in the future, is to try and decide or dissect whether or not oral contraceptive use plays a role there. So what I'm going to try and convince you of today is that cardiorespiratory and vascular function plays a role in this tolerance, as well as brain blood flow and autonomic function. And we'll go step by step. So first off, we have the cardiorespiratory function. So these graphs are very busy. I have to apologize. It's the first one I did as a principal investigator, so I had too many lines on the graph, but I'll walk you through this. What we've got here is stroke volume on the y-axis of the first panel and heart rate on the y-axis on the second panel. And this is during a supine sit to stand test. So they were lying down for 5 minutes, sitting for 5 minutes, and standing for 10 minutes. And we measured the stroke volume and the heart rate at the end of each one of those postures. We have a male line, which I'm not going to talk about today, but we have women that are not on oral contraceptives in the circles, women that are on oral contraceptives in the triangles, women in the low hormone that are the solid lines, and women that are high hormone in the dotted lines. And what you can see from this first panel is that both oral contraceptive use and the high hormone phase increased the stroke volume index in these women. So at the top here, you can see, oops, sorry, I brought the menu down there, but you can see that both of those variables increase stroke volume, which would be protective of orthostatic tolerance. If you have greater stroke volume, you have greater cardiac output. And in regards to heart rate, you can see that the dotted lines, which are the high hormone phase, this is the highest, or sorry, a high hormone phase increased the heart rate, which contributes to their greater cardiac output, which again could be protective of orthostatic tolerance, which is what we saw earlier when that was actually the lowest lightheadedness in those three groups that we looked at, not we, you looked at. In regards to ventilation, changes in ventilation it could be either protective of orthostatic tolerance or not. It depends on exactly what you're looking at. But what we've got here is ventilation on the y-axis, and then we have a supine baseline, and then an upright tilt for 5 minutes. So this tilt marks the 3rd minute of tilt. This normoxic period marks the 5th minute of tilt. And we have men again in the triangles, but we have the two groups of women in the circles and squares. The high hormone phase or the mid-luteal phase are these white circles. The low hormone phase are these gray squares. In the high hormone phase, throughout this entire test, even at baseline, the high hormone phase did breathe more. They ventilated more compared to the low hormone phase. Now, why I'm saying this could be either protective or not for orthostatic tolerance is this greater ventilation could be from it causing a greater respiratory pump. So when you take a big breath in, you're going to be bringing more venous return back up to your heart, and that's going to increase your stroke volume and be protective. And it can be dropping your end-tidal CO2. And your brain blood flow and your end-tidal CO2 basically go hand in hand. So if your end-tidal CO2 goes down, so does your brain blood flow, which I'll show you in just a second. So in yet another study, we had non-users, oral contraceptive users, low hormone phase, and high hormone phases. I have all of this anthropometric data here just to show you that these groups were pretty much the same size, the same BMI, the same leg volume, same predicted VO2 max, et cetera. These were the same sized people. And then this is their resting end-tidal CO2, which follows from the last graph about ventilation. Both the high hormone phase dropped the CO2, as well as the oral contraceptive users, which I showed at the very beginning that oral contraceptive users had a greater ventilation compared to the non-oral contraceptive users. So that means if you think about just the relationship with brain blood flow, that means high hormone phase might actually be non-protective, if that's a word. It might actually cause some orthostatic intolerance. So there's definitely throughout this whole talk, there's going to be things that are pro-orthostatic tolerance and things that are anti-orthostatic tolerance. And I'm hoping that by the end, we might come to a conclusion. So just to sum up what we've got there for the cardiovascular, the orthostatic tolerance could be higher in in oral contraceptive users and the high hormone phase because of that greater stroke volume and cardiac output. The orthostatic tolerance could be higher in the oral contraceptive users and the high hormone phase due to higher ventilation, causing a bigger respiratory pump, or it could be dropping the CO2 levels to therefore drop brain blood flow levels, which we'll start talking about right now. So in yet another study, but this is now a standing study, this is now looking at the first 30 seconds, not that last 10 minutes of standing. So this is where you're going to see a nadir in blood pressure and brain blood flow. You're going to see a drop in those values within that first 30 seconds. And we have, again, we've got non-oral contraceptive users in the first 2 bars, oral contraceptive users in the second 2 bars with low hormone and high hormone. We've got change in MAP. You can see the mean arterial pressure drops by about 15 millimeters of mercury just within that first 30 seconds of standing. And you've got an increase in cardiac output and an increase in heart rate. And just in this first 30 seconds, in regards to these hemodynamic shifts, there's no effect of menstrual cycle or oral contraceptive use. However, we found something interesting here. In this first drop in blood pressure, we actually found 7 out of 21, or 33% of our women had what would have matched the diagnostic criteria of initial orthostatic hypotension. But it only happened once, not twice during their menstrual cycle. So this is a low sample number, so we can't decide whether or not there's significance there. But what's of note to clinicians, I think, is that women might need to be tested more than once through their menstrual cycle for initial orthostatic hypotension, because you might catch it at one point and you might not catch it at another. But moving back to the brain blood flow story, this is the same study where we've got the 30-second nadir of brain blood flow and the same groups where we have non-users and users, as well as low hormone and high hormones. If you look at the diastolic and the systolic mean blood flow velocity in the middle cerebral artery, there was no effects. But when you look at the mean, there is now an effect of both oral contraceptive use and menstrual cycle, particularly in the oral contraceptive users. So the oral contraceptive users in the low hormone phase had a bigger drop in their mean middle cerebral artery velocity. And then in their high hormone phase, that was attenuated and was actually a smaller drop than you saw in the non-oral contraceptive users. So because of the fact we see this biggest drop in the placebo pill week of the oral contraceptive users, this means that this is a chronic effect. So this effect is basically because these women have been taking this pill for months, because there's no active estrogen or progesterone or analogs there during this time period. Whereas in the high hormone phase, now we do have those analogs of estrogen and progesterone in this active pill. Now we actually have this, what might seem to be a protective effect of brain blood flow falling during this first 30 seconds. There was no difference in the non-oral contraceptive users. So this is a new study, and we wanted to see whether or not, because one of the standard tests of brain blood flow is getting somebody to breathe hypercapnia to see what happens to their brain blood flow. So what we did is we got these women to breathe hypercapnia 5% CO2 for 5 minutes, and we comparing the baseline to the last minute of hypercapnia. And once again, we have the non-oral contraceptive users, the oral contraceptive users, the low hormone and the high hormone groups. This is the change in blood pressure from that baseline period to that 5th minute of hypercapnia. And there was an increase in pressure, but there was no difference between the groups. However, there was an effect of the change in middle cerebral artery velocity, where oral contraceptive users had a significantly greater increase of their brain blood flow compared to the non-users. Okay. When we divided one by the other to come up with a resistance index, I think that might be me. There was actually no difference there. So if there was no difference in resistance index or flow per se, we thought that it might be due to autoregulatory differences. So one of the common ways of measuring autoregulation is through something called transfer function analysis. And with transfer function analysis, you need to have beat-to-beat data from the middle cerebral artery and also beat-to-beat data from blood pressure. So I'll walk everybody through this. On the top, this is the beat-to-beat data of the cerebral blood flow velocity in red. And at the bottom, there's the beat-to-beat data from blood pressure. And what you're doing is you're just going to be comparing those two. You're basically overlaying them on top of one another to see how well they match. And you're also going to be breaking them down into the frequencies that control each variable. So each variable is going to have 3 frequencies. There's something at high frequency, low frequency, and very low frequency. You can think of it as the high frequency controls that at very fast rate, maybe within a second or two. The low frequency controls at a slightly slower rate, maybe within about 15 to 30 seconds. And the very low frequency controls these things in the minutes, like 2 to 3 minutes or something like that.
It's not gone yet. Why not?
Definitely not me. Okay, I got it. In terms of the spectral analysis, that's what we've got here. We have we've dissected each thing into the brain blood flow and the blood pressure into low, high, low, and very low frequency parameters. When we overlay them, we look at coherence. The coherence is how well one matches the other. If they match perfectly well, you have a coherence of 1, which never happens. But that's what you're looking for. And that's just basically testing the quality of the data. You're also looking at the phase. The phase is how much of a time delay there is from the blood pressure change to the brain blood flow change. You want a longer delay in somebody with really good autoregulation, because you don't want an immediate change in your brain blood flow when your blood pressure changes. You want to have that autoregulation where there's a control of flow. In regards to the gain, this is how sensitive it is. So if your blood pressure changes, does your brain blood flow change in exactly the same manner, or does your blood pressure change and your blood flow just changes a little bit? And that's what you want to see in your autoregulation, is you want to see a low gain. So in regards to the high frequency, I've basically picked out just a few things here, but high frequency again is the things that control your brain blood flow quickly. And what we've got here is the high frequency control during hypercapnia. And you can see that in these high hormone phases of both the non-oral contraceptive users and the oral contraceptive users, there's an increase in that high frequency control of brain blood flow during these phases that have exhibited less lightheadedness during the high hormone phase. So this greater fast frequency control might actually be protective of these women in this phase. Similarly, looking at the very low frequencies, so this is now the minutes, in these phases that actually had orthostatic intolerance, there is a drop in very low frequency control of their brain blood flow. So this is acting much slower, but there is a drop in its control in this hypercapnic environment. And the phase, so remember this is the time delay from one to the other. This is now where we're getting a little bit confusing, and if anybody has any input for me, I would welcome it. But now we have a three-way interaction where both menstrual cycle and oral contraceptive use influences the autoregulation in the low frequency. This does correlate with what I showed you earlier with the nadir response of brain blood flow, especially in the oral contraceptive low hormone group, where we see reduced autoregulation in this group. And in that 15-second period of time where I showed you that 30-second stand, this does actually correlate. So maybe it's because of poorer autoregulation that women in the low hormone phase who are taking oral contraceptives have that. And this is, excuse me, this is again going to be a chronic effect because it's during the placebo week. We don't know how long these chronic effects last, and that might be future work, is to determine how long, if you stop taking oral contraceptives, how long do these effects last? So just to sum that up, we've got the oral contraceptive low hormone group may have impaired autoregulation during standing, potentially contributing to orthostatic intolerance in this phase. The oral contraceptive users have greater brain blood flow response to CO2. There is better high frequency control or fast control of the brain blood flow velocity during carbon dioxide, breathing carbon dioxide, or that could be during brain metabolism because you create CO2. And this is during the high hormone phase. And this is, again, might be protective of their orthostatic tolerance, which is what I introduced this section with. And there is worsened very low frequency control in the low hormone phase, perhaps contributing to their orthostatic intolerance. So that wraps up the brain blood flow section before I move on to autonomic reflexes. Does anybody have any questions there? Hopefully not too confusing. I'll sum it up again at the end. Okay. So some of the reflex that are involved in the upright posture include the metaboreflex, which is the creation of metabolites, thus increasing your sympathetic activity. You've got the mechanoreflex, which is from the mechanical forces on your muscle. So that can be pressing a muscle. It can be passively moving a muscle. That's going to be your mechanoreflex, so stretch reflex. Your CO2 chemoreflex is active, but it's actually more inactive during the upright posture. because when you're upright, your end tidal CO2, which is representative of your arterial CO2, actually drops. But there are regions of your brain that are undergoing metabolism that might actually have more hypercapnia, if you think about it at a more microvascular scale. The baroreflex has been done by groups other than myself, but I'll show you a little bit of data on that. This is looking at actual microneurography data in women and men. The men are the black triangles. The women are in the high hormone phase are the gray circles. The low hormone phase are the white circles. And this is during a 45-minute tilt. It's a very long tilt to ask people to undergo. And you can see that the high hormone phase actually has greater sympathetic activity throughout this tilt. And this could be protective of their orthostatic tolerance during this phase, which is, again, what I'm trying to show everybody is that during this high hormone phase, there is protection of the orthostatic tolerance. And that same group, I should go back a bit, this same group did look at baroreflex function, looking at giving them phenylephrine and nitroprusside to cause big changes in blood pressure. They didn't actually find any differences in their blood pressure, or sorry, their baroreflex function according to menstrual cycle or oral contraceptive use. Actually, they didn't do oral contraceptive use, apologies, but they didn't look at, they didn't find a difference in menstrual cycle. What I did instead, because I couldn't give people drugs at York University, is we did the Valsalva maneuver. So what that is you take a deep breath in and then you blow against resistance for 15 seconds, and then you take another deep breath in. And you should end up with a blood pressure tracing that looks like this one, where you have a slight increase and then a big decrease. And then in this, what's called late phase 2, you have an increase in blood pressure. And this is a pattern similar to what is seen during the first 30 seconds of standing up. And what we found when we looked at the non-oral contraceptive users and oral contraceptive users in the high hormone phase is that there were strong trends for a greater blood pressure response in that high hormone phase, implying that this late phase 2 would have had a greater increase in blood pressure, or trend. These were trends, unfortunately, but they were 0.05, 0.06. But still, nonetheless, in this phase where we expect greater orthostatic tolerance, there was a greater blood pressure increase. So one more reflex that is influenced in the upright posture is the metaboreflex. So the way that we test the metaboreflex is we put a blood pressure cuff on the forearm and we inflate that blood pressure cuff after they've done 2 minutes of exercise. So they've done 2 minutes of exercise at 40% of their maximum. We inflate the cuff, they stop exercising, and we've trapped all the metabolites in their forearm. So there's no mechanoreflex here because they're no longer physically deforming their muscles by exercising, but it's all those trapped metabolites that are activated. So what we've got here is a change from baseline to that activation of the metaboreflex. And we do have an increase in mean arterial pressure across the board in non-users, users of oral contraceptives, the low hormone and the high hormone phase. But what's interesting to note is that the oral contraceptive users have a lower response to metaboreflex. So all that metabolite creation that might occur during standing up or during this arm exercise, the oral contraceptive users are less capable of increasing their blood pressure in response. So for the mechanoreflex, this is the other half of the exercise pressor reflex. The mechanoreflex, again, is that passive movement of a muscle or that physical deformation of a muscle. What we did here is we put a blood pressure cuff around the lower, right below the knee, and then we physically move somebody's leg for them between 0 and 90 degrees. And what we noted here is that, again, the oral contraceptive users in these gray bars had a drop, or they didn't have an increase in mean arterial pressure. So they had a smaller blood pressure response to this other half of the exercise pressor reflex. So if you add those two reflexes together, that's the whole exercise pressor reflex, and the oral contraceptive users had a depressed response to that. So in the upright posture, particularly during standing versus tilt, when you're using more postural muscles, the oral contraceptive users are going to have a suppressed blood pressure response to that. And in regards to ventilation, and once again, ventilation is one of those things that it could be pro-tolerance or anti-tolerance. So what we found here is that in response to giving these people 5% CO2 to breathe again, we found that in the high hormone phase of both the non-users and the oral contraceptive users, that the high hormone phase had a greater ventilatory response. So this could be protective of orthostatic tolerance, which is what we see in that lightheadedness graphs, because they would have greater respiratory pump action, pulling blood back up to their hearts via venous return, or it could be against orthostatic tolerance because you're going to be driving down your CO2 levels. So the results on ventilation are still equivocal. We need a lot more work there to figure out whether or not changes in ventilation are protective or not protective of orthostatic tolerance. But to sum up the autonomic section here, we've got greater sympathetic activity in that high hormone phase, could be protective against orthostatic intolerance. The oral contraceptive users have a lower blood pressure response to the exercise pressor reflex, which is activated during particularly standing and somewhat during tilt. And then this greater ventilatory response to CO2 could be protective or might not be, depends on what happens to the CO2 levels as well as the brain blood flow levels. And we don't unfortunately have them at the exact same time. So that'll be some future work, is looking at these ventilatory changes as well as brain blood flow at the same time, just to see what's going on there. So in regards to whether or not these three parameters could influence orthostatic tolerance through the menstrual cycle or with oral contraceptive use, the answer is a firm yes, that they all could be influencing orthostatic tolerance. The cardiorespiratory function, the brain blood flow, as well as autonomic function. So just to sum up everything that I've got here, this was a little shorter than I anticipated, but it's good, hopefully lots of questions. But in the high hormone phase, which is the phase that we know has greater orthostatic tolerance, they do have higher stroke volume, heart rate, and cardiac output, which is protective of orthostatic tolerance. However, they do have higher ventilation and lower end-tidal CO2, which again could be positive if you're thinking about the respiratory pump, or it could be against orthostatic tolerance because of the drop in end-tidal CO2 and brain blood flow. They do, however, have greater sympathetic output, which would be increasing peripheral resistance and blood pressure. So if I were to sum all this up, I would say that the total effect is that the high hormone phase exhibits orthostatic protection or orthostatic tolerance. Looking over here at the oral contraceptive use, the oral contraceptive users have greater ventilation as well as lower end-tidal CO2, which again could be protective, could be non-protective. They do have a greater brain blood flow response to CO2, which could actually be against orthostatic tolerance, because again, in that upright posture, your arterial PCO2 levels are lower. So if that's following, your brain blood flow might have a greater drop in oral contraceptive users. And they have a lower blood pressure response to the exercise pressor reflex. So all the buildup of metabolites and use of your muscles during that upright posture might not increase your blood pressure as much as in a non-oral contraceptive user. So if I were to sum all that up, I would say that oral contraceptive use is actually leading to orthostatic intolerance. But I don't personally have the data yet to do an orthostatic tolerance per se. I haven't yet gotten ethics approval to force people to faint. So I'm still working on it, but that's probably going to be the next step. So hopefully you don't all feel like this little girl down here right now after this talk, and hopefully some questions might elucidate some of your concerns. But I was just going to sum up acknowledging my grad students who were responsible for all of this data, as well as a whole ton of undergrad research students who helped me collect all of this data. So thank you guys very much.
Either way, thank you, Heather, for an interesting talk. We're open for questions. Sophia?
Thank you very much, Dr. Edgell. Really, congratulations on this body of work.
Thank you.
I have a few questions that maybe I'll roll into one. So you commented on exogenous hormone use. It's limited to the birth control pill or also extends to other contraceptives? And my follow-up question is,
Yeah, those are really good questions. I don't think it's just limited to oral contraceptive use, or it's expanded to all types of hormonal contraceptive use, IUD, patches, etc., as well as hormone replacement therapy in menopause. So I think it's just that this model was the easiest one to study right now, but that's something that I want to get into, particularly IUDs. There's a lot of people at the university level that have hormonal IUDs, and I'd like to investigate that. There's no there's no cycle per se, but in most of the women that have hormonal IUDs, but it would be very interesting to compare them to non-users. Can you remind me of your second?
Yeah, no. Do you think it's like you're on the birth control pill and you're on estrogen?
Right.
Yes, no, or do you think it's a dose effect, or do you think it's progestin and or?
So for those in the audience, what Sophia was trying to yell out was, is the benefit or harm of birth control related to the estrogen and dose or the progesterone agent?
So my answer to that is I don't know. So this is again the problem, not problem, but part of the model is that with these oral contraceptive users, that high hormone has both. There are a lot of researchers out there that have the late follicular phase, which has just estrogen. We haven't quite got there yet. So I personally think the progesterone is what's responsible for the ventilatory differences because it's a well-known ventilatory agent, and the estrogen is probably more responsible for vascular or hemodynamic differences.
So actually, there's a question from Catherine Kavanaugh. Catherine, do you want to unmute yourself and ask?
Yes, thanks. Very interesting talk. I was just wondering about, I think these were all young people that you were working with, how it might change over age. Have you looked at that? Were they all on the same type of oral contraceptive, how that might have affected your results? And also from competition wise, and I'm just wondering in Olympics, is that something else they're going to look at as far as when they compete and how they compete?
Yeah, those are all really good questions. I did a study during my PhD on age, so I did a postmenopausal study. I haven't done that quite yet as a PI. What I noticed in the aging group, I only did hemodynamics, but I noticed that there was a smaller heart rate response because there was a greater stroke volume response in the postmenopausal women. So they were responding more with positive hemodynamic differences. The second part of your question was the type of birth control. So we only controlled for the fact that they would have 1 placebo week and three weeks of pills. Whether that be the dose or the generation of pill, we didn't control for that. But that's something that my PhD student wants to get into because it has been shown that the generation of pill can definitely influence the vascular function. And part 3, I already forget, sorry.
The competition and
Olympics.
Yeah.
I do think that I think that it is probably very important to look at. I don't think at the moment that any type of oral contraceptive use is on the World Doping Agency's list right now, but that might be something to consider, or maybe that's what coaches are already considering.
Okay, thank you.
Carlos?
Yeah, that was a great talk. I have like 1,000,001 questions. The first one is that you show that the 3 main mechanisms kind of play a part, but which one is the main mechanism? I was wondering if you'd done like the lower body pressure kind of thing, 5 millimeters,
Right.
you just look at low body mechanoreceptor. And you also spoke about the chemoreflex, but you didn't give us a lot of information on how much the chemoreflex is involved in all this. And finally, more of a question in the doping side. There's a lot of transgender people that have both competition of being on testosterone and estrogen and oral contraceptives. How does that affect the mechanism? A lot of them actually have a personal experience, but everybody knows that I have trans male kid and need a lot of orthostatic tolerance.
So let me try and summarize some of that. That question from Carlos reminded me of the famous Rodney Dangerfield movie Back to School, where in the final oral exam, the examiner had 1 question. He got all excited and he said with 23 parts. So I think the first part had to do with, Heather talked about 3 different mechanisms, and Carlos was interested in the relative importance of each of those in terms of orthostatic intolerance. The second I think, asked about using a model such as lower body negative pressure to perhaps lower preload a little and see the effects on some of the reflexes. The third,
Trans patients.
that was 4, I think. The fourth was the effect on transgender patients, and the third, what was the third? We'll get to that. We'll get to the third after. Go ahead, Heather.
So I used lower body negative pressure in my PhD, but I haven't yet instigated that in my current lab. That could be interesting because particularly at the less than minus 20 level, because that would be looking at the cardiopulmonary barrier reflexes for the arterial barrier reflex. So I can't yet tell you whether or not that plays a role in what I'm looking at. In regards to the chemoreflex, that's a little bit in regards to orthostatic tolerance. I alluded to it at the end because I've been giving people CO2 to breathe rather than in the upright posture, CO2 levels drop. So what I need to do is a hyperventilatory response and then breath by breath, give them more CO2 to breathe. So I don't have that capacity at the moment. Well, I can do the hyperventilation, but I don't have the breath by breath system. I think that in these, if I were to weigh the reflexes, I would say barrier reflex is the most important, followed by the exercise pressor reflex, and then the chemo reflex. If I were to,
You also mentioned that you did some, flow rate
Yeah.
stuff because, all these contraceptives have mechanisms on endo reduction, which could also explain part of the mechanism here.
Yeah.
So I was wondering if you thought about, looking at, blood flow, looking at vascular reactivity.
L name and that sort of thing. I would love to do that. I think at York University, I can't do that. Yeah. So I think that's an area of research that I'd like to do. It's just that my RAB isn't going to let me do that.
So Carlos is trying to get her to do nitric oxide synthase infusion studies with blood flow.
And last, you asked about transgender and how all of these hormonal milieu will affect. And that's, again, another area of interest of mine. I think that even testosterone can increase orthostatic intolerance. So if you have estrogen, progesterone, and testosterone, you're going to be experiencing a great deal of orthostatic intolerance. So I think that it's a very, very good area to get into. Did you have a more specific question? But I don't have the answer right now.
Now, Sophia is doing a lot of work in transgender stuff. We may have to get her patients tilted now routinely. So there's a question on the chat about wondering if you're going to veer into more pot stuff. I know you do some stuff, but maybe you could speak about that.
Sure. So I do already have a study started with POTS in the menstrual cycle. I was stalled because of COVID. I'm hoping to get it started up again right away. And so I've got 4 women done, 4 POTS ladies done, and we were looking at heart rate, ventilation, et cetera, during tilt. All I can say right now is there's a tendency for women in the low hormone phase POTS to have a greater heart rate response. That's all I can really say for now, but I am in the middle of that study.
Just the question had to do with hormonal changes in pregnancy and its effect on orthostatic tolerance or reflexes or one of those.
Any of the above? No, unfortunately, I haven't done pregnancy, but I know there's a group in Edmonton, Margie Davenport's lab, that does a lot of pregnancy work. So, and they also do a lot of these reflexes, cold pressor tests, et cetera. So I think that they've got those bases covered.
How about the setting tolerance of COVID? Women.
So I'm doing a long COVID study, but I'm doing an inspiratory muscle training study. So I know that Satish has a long COVID study going on with orthostatic tolerance. I'm doing it pre and post inspiratory muscle training. And so far it looks positive, and we've got a couple of patients with their feedback, and they don't see any differences in their fatigue, but they are seeing differences in their brain fog. So we think that that's positive, so that the inspiratory muscle training might be bringing their end tidal CO2s back up or their hyperventilation down, as the case may be. And then that's going to be improving their brain flow and reducing their brain fog.
Go ahead.
I was just wondering if you have like a
yell at the question.
So the question was on the initial orthostatic hypotension and whether or not there's a plan to pursue that. I think the only way to pursue that is greater sample numbers. So we only had 21 women and a third of them had that initial orthostatic hypotension. I think we just need lots more women.
Was that in one phase or was that split between
That
the two
was,
phases?
there was no pattern with the small sample numbers, but 7 of the 21 had it in only one of the 2 phases.
But not always.
Not always the same one. So I can't say more than that. Yes.
So what I expected was that
So I'll just repeat for these guys. The question is, so she would have thought that because oral contraceptive use has greater hormones than the high hormone phase of menstrual cycle, that orthostatic tolerance would have been better, right? Yeah. So how do I reconcile that? I think that this is hypothetical, but the exogenous hormones that you have in the pill are not real estrogen and progesterone. So I think that that's where the differences lie. And that gets back to the cell biology that I mentioned in regards to that those pharmaceutical versions of the drugs might be influencing the genomic and non-genomic pathways differently than the natural estrogen and progesterone, but that's purely conjecture at this point.
Wonderful. If there aren't any burning questions, I will close the session there and thank Heather for
Thank you.
that interesting talk that generated lots of questions and certainly years of work to follow, which is the sign of any good research. Thank you all for attending.
Thank you.
I have to run the thesis committee meeting next week. Yeah, I'm in.
Great, thanks. I gotta go to clinic.
Just end or do we have to do something else before we end?
Yeah, and
Yeah,
Wonderful.
exactly.
Thanks, Charlotte.